Susan. So she's someone who is a distinguished person in the field of psycho-oncology. Most of us would definitely would have come across her. Her name is Dr. Elizabeth Akindoye. She's a clinical psychologist, psycho-oncologist at the University College Hospital, Ibadan. She's also the president of the Psycho-Oncology Society of Nigeria. She has distinguished herself in terms of research, clinical training, not just in Nigeria, but also in Africa. And she has a special specialty, pediatric psycho-oncology. And so we're listening to a seasoned person who's going to tell us what we need to know as clinicians and healthcare professionals when it comes to psychosocial screening for children and also adolescents. So please make welcome Dr. Elizabeth Akindoye. Thank you so much, ma'am. The floor is yours.
Thank you very much. Okay. Thank you very much, Dr. Sarimiye, for that warm introduction. Can you see my slide?
And yes, we can.
Great. So, like Dr. Sarimiye has said, I am Elizabeth Akindoye, and today I have the pleasure to be speaking on the psychosocial screening for children and adolescents, cancer patients, and survivors. And before I actually start, I'd like to appreciate the presence of Professor Chioma Asuzu, the IPOS president. It's an honor for us to have her in this gathering because I saw her name scroll through when she joined the room. Thank you so very much, Ma, for creating the time to join us this evening. Okay, so the objectives for this presentation are just simple: to define psychosocial screening in pediatric oncology, explain the rationale for the screening in pediatric oncology, identify psychosocial domains in pediatric oncology, present pediatric psychosocial oncology screening tools and strategies that we could use, and as well as discuss the implementation in clinical practice. Okay, in a way of introduction, the World Health Organization estimates that over 400,000 children are diagnosed with cancer every year. And in Nigeria, children make up about 7.2% of the 127,000 cancer cases that are seen annually. Over 85% of children in sub-Saharan Africa diagnosed of pediatric cancer are likely to lose their life yearly, primarily due to poor access, illiteracy, which also leads to late detection of the ailment, and then treatment abandonment, financial burden, as well as poor family support. And so children and adolescents with cancer, are a highly vulnerable people, along with those that take care of these children. Because from the point of diagnosis to the treatment to survivorship or end of life, there are always one form of distress or the other. And this underscores the need for psychosocial care for people affected by pediatric cancer. Okay, so the socio-ecological approach to child health is a holistic framework that analyzes how interconnected factors or interconnected variables, at the individual level, say the patient's level, the individual parents or siblings level, and the interpersonal level in terms of relationships at school, in the neighborhood, and all of that, at the community and society at large. All of these factors shape, first and foremost, the child's development and also the child's well-being. So it moves beyond just the individual, to focus intervention to address the broader environmental factors, including cultural norms, the policies that guide the healthcare of these children and the physical environment in which they live. And we know that children on their own can really do nothing to help themselves. And there's this bi-directional relationship between the child and the family from which they come, and how they are able to cope with the disease and its aftermath, is highly interconnected. And so it's important to have a holistic view when addressing issues in pediatric oncology. And then in terms of the social determinants of health, which refers to the conditions in which people live, right? Their environment, where they live, they work, they access healthcare. This condition significantly also impacts pediatric oncology outcomes, especially in terms of lower socioeconomic status, the lack of insurance that is linked to high mortality, and as well as advanced stage of the disease at diagnosis. And of course, it also affects the long-term survival of these children. So addressing social determinants of health is critical, because factors such as where the individual lives, in terms of housing instability, transportation to the places where they will access care, having balanced diets, and all of these have implication for a child's health. So psychosocial screening is the first effort at identifying the psychological and social factors that can impact the initial response to diagnosis, ability to manage the demands of treatment, as well as the long-term outcomes for pediatric cancer patients and their families. Holistic care is the treatment of the total person, considering their needs across multiple psychosocial domains, such as the physical domains. Is this child experiencing pain? Are there sort of some form of physical deformation or disfigurement due to the disease itself, or as an aftermath of the disease treatment that could involve amputation of body parts? The experience of certain symptoms that are not properly controlled are areas that should be looked at, because when we look at the domains of human development, a negative impact in a particular aspect will cut across most of the other aspects. And so there's a need to address this. And then the emotional domain that has to do with anxiety and fear, say procedural anxiety that patients may experience, anticipatory fear for parents sometimes when children are experiencing this kind of issues that are worth paying attention to in pediatric oncology. There's also that area of the social domain that has to do with interpersonal relationship, peer relationship, because this child belongs to a school, a religious center. In their neighborhood, there are children they also play with. And a disease like pediatric cancer could impact this relationship and how the child sees himself or herself vis-a-vis how others view them and are willing to relate with them. Under the social domain also, we may look at the family dynamics and the economic status, of this patient's family members. And because this also have great implication. Then cognitive domains in terms of attention, memory, learning difficulties, because most of these children, some of them are school-aged, usually the adolescents, early childhood, those at the early childhood stage of development. They are already, some are already in school. And so this also have implication for their scholastic or academic performance. And then I also think we also need to look at the behavioral component also, because sometimes children may start acting out because of the illness, because maybe poor communication, the side effects, they may engage in risky behaviors, they may stop adhering to treatments, they may have difficulty coping. And so part of these psychosocial domains and having an holistic view is being able to assess, screen for how this child is coping and dealing with this condition. So what is the rationale, or what are the rationales for psychosocial screening? You know, let's put it out there. I mean, if you've worked with children in pediatrics or their parents, you'll find out that many of them are quite resilient, right? But despite this, some still have concerns that are high enough to impact how they are able to manage the disease outcome and the disease process. And so the goal of screening is to identify those at greatest risk of psychosocial problems as early as possible, so that interventions can be provided to mitigate the both the short and the long-term impact of those risk factors. I mean, the general idea is to even prevent those risk factors from manifesting, because if we never screen, then we are never able to find out. And then this preventative approach also increases the efficiency of workflow by placing attention and resources on where it is most needed. And that allows for equity. It allows for a reduction in health disparity when we are able to place resources, care, and attention for the fitting resources to the particular need of each individual. Also, when we screen for psychosocial functioning in pediatric oncology, we are aligning our practice with the standards in the National Pediatric Psychosocial Standards of Care and the recommendation of key professional societies, right? That psychosocial functioning should be assessed, psychosocial distress should be assessed as a sixth vital sign. Then psychosocial screening also fosters effective communication between the multidisciplinary healthcare team. So ordinarily, you may not have a psychologist treating a cancer patient, but when you have a multidisciplinary team, each one is able to bring their perspective, the perspective of their training, to bear in the care of these patients. It also fosters communication between the healthcare providers and the family. And this is very important to promote adherence to treatment and to help address the fears of the family members and of the patients that may make them abscond, from assessing or from continuing treatment. And so when we include psychosocial indicators, institutional, local, or national cancer registries, it could also help inform prevention and intervention policies and programs at various levels. What is not assessed seems not to exist. But once it is assessed, it is documented, then it is easy to use this data to allow us drive policies based on information. So there are several tools, right, for assessing, for screening in pediatric, for psychosocial oncology screening in pediatric cancer. And there are some tools, a few tools that are cancer specific, pediatric cancer specific. There are others that are generic, but some have been commonly used in cancer, in pediatric cancer. And so one of the most common tools is the psychosocial assessment tool, PAT. It's a standardized psychosocial risk screener, particularly used in pediatric oncology, and is based on the preventative health model, psychosocial preventative health model. It consists of 7 subscales, looking at family structure or resources, family problems, social support, to admit somebody. Okay, social support, family beliefs, the child-specific problems, and the sibling problems. And so this tool assesses all of this. This tool is freely available, but is based on request. There's also the pediatric quality of life inventory, the cancer model. There's also the generic form, but this one is specifically for pediatric cancer. It is also free for non-funded research. So it's just a matter of contacting the developers, and they will make it available. And so this pediatric quality of life inventory has 27 items. And the beauty of it is that it has different skills specific to different developmental level. And so there is that scale for even toddlers, 2 years to 4 years. This is purely parent reported. And then there are also those skills that have both the self-report and the parent proxy report for children 5 to 7 years, 8 to 12, 13 to 18. And there are even versions for adults. There are even versions for adults. So it assesses problems related to pain and hurt, nausea, procedural anxiety, treatment anxiety, worry, cognitive problem, perceived physical appearance, and communication. And so we see that this quality of life inventory, the cancer module, covers a broad range of psychosocial concerns in pediatric oncology. We also have those other general psychosocial screeners, which I will not be describing in detail, but something that we could Google, and they are freely available online. But worthy of note is the pediatric distress thermometer rating scale and the distress thermometer for parents. The distress thermometer is one of the most common tools that is used in adult oncology. And its use is being extended to the pediatric context, with versions tailored to patients and another tailored to the parents. So it screens for distress on a visual analog scale that appears as a thermometer. So on a scale of 0 to 10, 1 to 10, the individual is able to cycle the level of distress that he or she is experiencing. And then there are other aspects where they could report where the problems really are in terms of the problem checklist, addressing emotional, physical, practical, social or family, spiritual concerns, and other problems. I would encourage you to just seek these items out on the net and use them or adapt them. But we should also note that these tools, while they are useful, screening does not equal diagnosis. We need specialists, we need experts, clinicians, to be able to make a formal diagnosis of whatever the patient or the family members may be experiencing. And as such, positive scores should trigger appropriate referral to a psychologist, a psychiatrist, a social worker, or depending on what is being indicated. So in describing those tools, especially the quality of life tool, we've talked about some of the typical areas usually assessed in pediatric oncology. And so important among them is the emotional distress. Something that is like a common, or I mean in literature, and that I've also found out in studies, is the fact that children with cancer do not often report high anxiety and high depression, but it does not mean that they do not have concerns. Their parents would often report higher scores on these disorders or symptoms of anxiety or depressive symptoms, right? But it's important to be able to screen them, ask them the specifics to understand exactly what their areas of concern are. And then family functioning and caregiver stress is also very important, right? Because after screening, then you are able to identify where does the stress lie, where can services or what sort of counsel will be needed to give to this individual. Sometimes there are existential crises or spiritual concerns that patients and their family members may have. All of these are what screening for. So these domains guide referrals and tailored interventions across diagnosis, treatment, and survivorship phase. So this is the pediatric psychosocial preventive health model. This model suggests that pediatric cancer should be viewed as an abnormal life event that happens to competent families. And that was why I stated earlier that oftentimes families affected by pediatric cancer, they are resilient, right? They are just regular families like yours and mine. But an adverse life event happens. And this individual also possess the capacity to adjust and to cope with this stressful life event as time goes on. But oftentimes, they need help. They need support to be able to get to that point of adjustment as fast as possible. So the expected pattern is, and I mean, initially, there's that intense distress that patients and their families may experience, and this may reduce over time with peaks at times of acute events, such as recurrence or progression of disease. So the pediatric psychosocial preventative health model is a tiered approach to care that stipulates all families should receive universal care at this base. So at the very beginning, everyone affected with pediatric cancer should receive a basic form of care at the least. Then, as you progress and with screening, we can now know after this basic universal psychosocial psychoeducation provided for all families, family-centered support, screening to identify high-risk group, then from that score, now using the PAT, psychosocial assessment tool, scores of 0 to 0.9 could still remain at that general group where we provide psychoeducation and all of that because they are relatively coping well. When the score gets to 1 or 1.99, these are targeted group where you want to understand what is the distress, how can it be resolved. Sometimes just being able to answer their questions may be able to resolve the issue that the patients have or addressing certain symptoms that the patient may be presenting with. But on that part, that is psychosocial assessment tool, patients who score 2 or more in the assessment would need more. It's indicative of clinical, a clinical level of distress that may need the consultation of behavioral health specialists, maybe a psychiatrist, a psychologist, depending on what the patient is presenting with. Okay. So, pediatric oncology survivorship screening consideration. Now, there are times when patients may have reached remission, no more cancer cells are seen in these patients, but we do not just want to leave them and let them go, right? We need to be able to realize that there are times when there are late effects, either cognitive, emotional, and social. And there's this routine clinic visits that they should have. And there's a need to have a tool that can screen for these issues and also issues related to return to school, school reintegration, and reintegration into the community to understand the challenges they may be experiencing and to help them, cope with these challenges as much as possible. And so this underscores the need for survivor-focused screening tools that helps us understand how these patients are doing, I say maybe post-treatment, after they've reached remission and completed their treatments. So, what are the principles of psychosocial oncology screening? And so for psychosocial oncology screening, we need to be able to answer those basic questions related to who, what, where, how, when. These are important questions to answer, when thinking about psychosocial oncology. And so, for instance, we may want to ask who, in terms of who needs this psychosocial screening? Who should perform the screening, right? We do know that in certain centers, there are shortage of behavioral health specialists that could undertake the task of actually screening the patients and their family members, but we must be able to determine the minimum qualification or the minimum kind of training that this individual or individuals would have to be able to assess these patients for psychosocial distress. And then in terms of who is also, what is the age of the person we are screening? Because there's a need for age-appropriate and developmentally sensitive tools. And that is why the quality of life instruments for pediatric oncology, it's a beautiful tool because it looks at children from across different ages of the developmental stage. And so being able to identify the who of the psychosocial screening is very important. When is also very important, right? I think part of the who is to say, is it a universal screening or is it a targeted screening? Are there specific people we are screening, right? As far as against, is it a universal screening? Then the when has to do with at what point of the treatment should screening be done? And I'd say that it should be done across the level of care, from diagnosis until survivorship, right? And long-term follow-up, because there's a need for that back and forth in being able to identify what the patient is going through. So there's that initial diagnosis, and then each clinic will then need to determine, because of resource constraints, each clinic will then need to determine at which specific point do we need to screen. Should we screen after each chemo, for instance, or should we screen before and at the end of specific types of treatments? So these are decisions that need to be made with the multidisciplinary team. And then there's a need to think about cultural responsiveness. The screening has to be culturally responsive. I mean, maybe in terms of language and being able to give cognizance to those that should be given cognizance to. So there's that need to respect different religions, cultures, and orientations, acknowledging inequalities and barriers encountered by some children and adolescents when assessing services. So these should be put into consideration when we are assessing children. Then the issue of confidentiality, consent, and assent is also very important to consider during screening. We know that the parents need to give consent, right, before screening is done. We must have that verbal consent and where possible, even document that consent. So while children, say less than 18 years, cannot give consent, they can give assent, right? At least they can say, okay. And so if the parents give consent and the child says no, we can't proceed with that screening, right? We only hold them the duty to explain why we need to screen. And that is why using the universal approach is important. And so the universal approach just says that this is our clinic's culture. Every patient that comes to our clinic is just the same way the nurses would take the vitals. So every patient that comes to our clinic would need to go through this distress thermometer, at least at the universal level. Then at the targeted screening level, the patients may then choose to either opt in or opt out, because there should be a standard of care. And then there must also be prompt scoring and interpretation of results, because if results are not scored promptly and interpreted, then we cannot appropriately triage our service use to the areas where they may best benefit from our services. So challenges generally with screening in pediatric oncology is the fact that there are limited resources and limited, dedicated psychosocial oncology staff. What we would usually have is people coming and going on consultation basis. But I dare say that every pediatric oncology clinic needs a dedicated psychosocial oncology staff that is assigned. And it shouldn't be one that is changed too frequently, because there's that sense of bonding, that sense of therapeutic alliance and relationship that needs to be built over time with patients, right? So that they can be open enough to talk about their problems without feeling odd about it. And then time constraints in clinical setting is also a huge concern amongst several clinicians. Political will and lack of political will and structure. So if there's no political will that would enact these policies, that will drive these policies to ensure that psychosocial screening is done as and when due, then it will be difficult. There are also cultural barriers and parental resistance. Then tool selection and validation of diverse population is also very important, because we know that even in the cancer setting, there are different, there are children with different types of challenges, right? Those that do not learn fast, maybe one form of learning disability or the other, neurodivergent children, for instance, may also be part of the population we care for in pediatric oncology. And so we do not have enough tools yet to address all of this. And so doing this would demand that sometimes, even within our clinics, we know the challenges we encounter, and we could design instruments and validate these instruments for our own setting and the kind of population that we serve. We may choose to translate validated instruments even into the local languages, right? And then oftentimes, even when psychosocial oncology staff go on this, on screening, sometimes this screening results are not documented. It is important that they are documented, and especially in clinics where they are now running electronic health records. It should be documented so that doctors that are coming, other healthcare providers, other clinicians seeing these patients are able to see social screening results and know how to act accordingly. Okay, so in conclusion, psychosocial screening is critical for holistic pediatric oncology care, and early identification improves mental health, adherence, and quality of life. Multidisciplinary, ongoing, and developmentally appropriate approach is key. One professional cannot do it all. Let's all bring our contributions to the table so that we could have more children surviving pediatric cancer in our settings. Thank you.